The final indication that I'd like to briefly mention is epilepsy. As you know, epilepsy is often treatable with pharmacological therapies. If they've got a definite seizure focus, you can either remove the temporal lobe, the mesial part of the temporal lobe, or you can remove an epileptogenic tumour or vascular malformation. But there are a significant number of patients that have epilepsy that don't seem to have a well-defined epileptogenic focus and that don't respond to pharmacological therapies. And it's thought that these patients might be suitable for deep brain stimulation. These are essentially the same patients that got the vagal nerve stimulators, which offer some patients a good benefit, but probably don't give as good a benefit as we would hope. So there have been a number of trials conducted, but the main trial is the Santé trial, which looked at bilateral anterior thalamic nucleus deep brain stimulation. They had over 80 participants. These patients had generalised seizures which had partial onset, so they had medically refractory seizures. They had a good median follow-up of 31 months, and they found that 60% of the patients experienced at least a 50% reduction in their baseline seizure rate, and the median seizure frequency was reduced by 2/3. So this was very encouraging, and there are now a number of centres starting to look at this for the treatment of epilepsy. We've only done one patient just because of the referral patterns. This patient was done about 2.5 years ago now, and he had Dravet syndrome, which is a myoclonic epilepsy that comes on during infancy. He had a range of intractable seizures. It was very hard to generalise and work out exactly which types of seizures he had, but he basically had every type of seizure that you could have. He had vagal nerve stimulation, which gave him a very modest benefit, and so he decided, or his family decided with him, that he would go down the path of deep brain stimulation. So we did intraoperative EEG monitoring, and what we found was that we could modulate his EEG patterns as we stimulated, particularly as we went out of the anterior thalamic nucleus and into the mediodorsal nucleus. We lost the ability to modulate his EEG, and he had a fairly dramatic effect in terms of his seizure frequency. But the thing that I noticed the most was that when he came back to see me in the rooms, when I saw him preoperatively, because he was having so many seizures, he was very, very drowsy. He just had this ongoing electrical activity. He was falling asleep in the chair. But when he came back post-op, he was quite alert. So that was probably the thing that I noticed more than the seizures themselves. So.